The public chat will be disabled until the end of the meeting. We're doing this so that the captions do not cover, or the public chat does not cover the captions. For questions, please use the Q&A button or raise your hand to ask a question. Next slide. My name is Denise Adams. I am the Vice President of the Greater Grand Rapids chapter, and I am one of your hosts today. We also have Tony Farrick from he is the President of the Michigan State chapter and also of Westland chapter. And he will be pushing the questions through to help the audiologists with those, making sure those get answered. We have Jared Adams in the background. He is the President of Greater Grand Rapids chapter. And you won't see him and you probably won't hear him, but if you have any technical questions, please make sure to hit the Q&A button and he will be happy to help you with that. Next slide. Our CART captioning is brought to you by Annette from Q&A Reporting. Next slide. Just a little etiquette for the meeting. Everyone will be, to promote good communication during the meeting, please observe the following. Everyone will be muted and no video will be on for you except for the audiologist panelists. When you wish to contribute to the discussion, please raise your hand virtually. The raise hand icon is either located at the bottom of your screen or the participants listed towards the bottom. If you raise your hand in real life, we won't see you because we can't see you on video at the moment. You will be given permission to unmute and display your video during your question in the order the hands are raised, at which time you may also have some short follow-up questions for further clarification. Asking a question via chat, you can ask your questions in the Q&A section. You can find the Q&A icon at the bottom of the screen when you move your mouse around. Q&A will be answered to the best of our abilities. If you want to be anonymous, please be sure to check the anonymous. Nobody will be able to see your questions, and you will not be able to see questions others have asked in the Q&A. To reduce misunderstandings, please use CART on the screen. If you answer questions, please be sure to repeat the question that is asked. This helps everyone in the room who is to understand the question and make sure they didn't miss it. Next slide. This is how you can ask your questions. So questions can be asked using the Q&A box or by raising your hand virtually. We cannot see your video again. Move your mouse or tap your screen to see the toolbar along the bottom. On some Zoom versions, raise your hand icon is in the participant list. So it depends on the device you're using sometimes. Next slide. The mission of HLAA is to open the world of communication to people with hearing loss by providing information, education, support, and advocacy. Next slide. We would like to thank Caption Call for sponsoring our CART services today. Next slide. We do have a team of volunteers at the Greater Grand Rapids chapter. And we are always looking for more volunteers if you have time to give. Next slide. Volunteers are also needed at the state level. Our Board of Trustee team is seeking another applicant. So if you are interested, please feel free to reach out to us after the meeting. Next slide. You can also help locally. And we do need bodies, brains, donation, and networking. If you have a few or a lot of hours, feel free to reach out to us. And we would like any help. We are all run by volunteers. Next slide. Just a few dates to remember. Our next Ask the Audiologist panel is scheduled for March 17th, 2021. And we, at this time, plan to have that as virtual as well. We also have the Walk for Hearing, May 22nd, 2021. And that is usually on the east side of the state. It might be virtual. As we have this meeting right now, National is actually having a meeting about the Walk for Hearing. So we should have more information, so look out for that soon. And we do usually have an annual meeting, and keep an eye for an update on that for later as well. Next slide. The Ask the Audiologist panelists consist of 4 panelists. We have Karson of Michigan ENT and Allergy, Darcy Jaarsma of Spectrum Health, Butterworth Audiology, Kim Kragt of Constance Brown, and Michelle Rankin of Rankin Hearing. We're so excited that they're joining us today. Next slide. Next slide, please. Okay, at this time, I'm going to turn it over to Tony, and we are going to start our Ask the Audiologist panel.
Thank you for the introduction, Denise, and thank you, panelists and captionists, for being here tonight to make this a success. So, as I was talking to Kim earlier, she was the first to join, so I was available to speak. So we did have a little conversation, and I just wanted to mention that that a lot of the questions we had posted on, we advertised this webinar on the HLAA chapter leaders group, and we also advertised on the Mayo Clinic hearing loss support group and the Michigan AG Bell Association. So the word's out there. So we have attendees from throughout the country here. So I welcome everybody to this. This is our first webinar. So thanks for everybody being here. And you can ask questions live, but we have taken questions in advance. So I'm going to start with these questions, and whichever panelist wants to chime in first, go ahead. And then if anybody, any other panelists have anything to add after that, then that's fine before we move into the next question. So everybody has different views on the way their practice may be run. So I'll start with the first question that came in remotely. I am a bilateral CI user, and my question is, what can be done or can I do to improve the clarity of the sound I receive? So I think we'll dedicate it for CI people first. So, and then I think we'll move it on, because that same question applies to people with hearing aids too. So for a CI standpoint, the process is a little bit different. So who wants to start with answering that?
I can start with that since I work with cochlear implant patients quite frequently. And really good question to start out with. Without knowing whether or not this person received their cochlear implants one at a time or at the same time, one of the things you can do is just to make sure that you have been visiting your audiologist and your programs are set appropriately for you. So if you haven't had a mapping in quite a while, sometimes that can make the difference in making sure that all the levels that we set are appropriate. Another thing you can do is to make sure that all of your equipment is functioning properly. So making sure that your microphone covers are changed. A lot of times if those mic covers get dirty, the sound is not going to be as clear. And making sure that your cables are working appropriately. And again, if you have questions about your microphones and the fidelity of the microphones, that is something that the audiologist can typically check for you. And then lastly, you know, there's all kinds of listening practice that you can do. And that can sometimes help improve your ability to understand speech as well.
Thank you, Darcy. Could you, and I think I want to give a better introduction, can you also explain, you did mention that you work with the CIs. Could you provide a little bit more background before, and I think I'll ask that for each of the panelists. So go ahead, Darcy.
Yeah, sure. Thank you again for having me here tonight. But yes, as a way of an introduction, my name is Darcy, and I have been an audiologist for 20 years, and I have spent the last 18 of them at Spectrum Health. So the audiology department at Butterworth, where I work, we do have a cochlear implant program. So we do cochlear implant evaluations for candidacy. We see both children and adults. And we also do diagnostic hearing evaluations on children and adults. And we manage the newborn hearing screening program as well.
That kind of is, leads up to another interesting point. The candidacy for a CI has changed throughout the years, I understand. And there is going to be a question later on regarding this, but could you explain what the candidacy requirements are now? Can a person have a one aided ear and still be able to get a cochlear implant, or can some people get two at the same time? Can you explain the how that's changed?
Yeah, so the candidacy criteria do change quite frequently. The basic candidacy requirements will depend on the type of insurance someone has. So Medicare has different criteria than individuals who have commercial insurance or private insurance. But basically, it's a little bit, it's a case-by-case basis. So the criteria depends on how much hearing loss someone has, how well they understand speech with their hearing aids. And so, yeah, sometimes someone will qualify for a cochlear implant in one ear and still be able to use a hearing aid in their other ear. Sometimes somebody can get 2 cochlear implants at the same time in both ears. It really is quite variable, and it's hard to exactly nail down specifically one set of criteria, because it really does depend on an individual case by case. But in general, the poorer somebody performs with their hearing aids and the poorer their hearing is, the more likely they will be to meet candidacy criteria.
Okay, so that's that is interesting. Now, and maybe this will be better for any of the other clinical audiologists that I have to assume that they are on board with this candidacy, because if you do so much for a patient, you can only do so much. And then, so at one point in time, the clinical audiologist may have to refer them to a CI audiologist, because there are two different steps, right? I mean, I can't go to my corner audiology and they're going to say, here, I'll fit you with a CI. It doesn't work that way. They have to go through a CI audiologist, correct?
Yes, but most of the time they do have an audiologist that helps them with their hearing aids. So before they get to that step, yes, it is their hearing aid audiologist that's helping guide them toward that direction if they need to.
Okay. And we just have another live question that I'll move on. I have an overall hearing loss, which gets worse toward the high end, but unusually comes back up appreciably above maybe 14 kilohertz. When I am using telecoils, I can hear high frequency amplifier hiss. It's pretty annoying. My audiologist says all hearing aids do that. Do you agree? So that's kind of a tough one, because telecoils can generate, you pick up things that you don't hear, electromagnetic hum. But why 14 kilohertz? That's kind of odd. But so I'm assuming that this person has hearing aids. So all hearing aids do that. So a person does have hearing aids, and they're obviously having trouble with their telecoil programming. And why they're coming? Why is he getting this high-end distortion? Has anybody got any thoughts on that?
I can jump in here. There's so much going on there. There are so many variables that could result in some hiss or any kind of high frequency distortion. It could be the amplifier system with the loop. It could be the hearing aids, if there's something going wrong with them, if it's just the model, the manufacturer. There is a lot that you would have to look at in order to figure that out. To say that all hearing aids would do that, I think is a stretch.
Could you give a brief introduction to yourself, Karson?
Yeah, sure. I am an audiologist at Michigan ENT and Allergy, typically out of the Grand Rapids Beltline location. I graduated from Rush University in Chicago in 2018, and a little bit of other background. I studied audio design and production, so music recording in my undergrad, and I'm an Army veteran.
Great, thank you very much. Anybody else want to add to that question about the high frequency distortion and how it can come back? Obviously a question for their own professional, I think. That's tough. All right, I'm going to go to the next question. Could each audiologist comment where they stand on recommending the telecoil in hearing aids?
Yeah, I can start with that one. So we definitely try to make that recommendation for telecoils. I'm from Kalamazoo area. Originally started out more in the Zealand, Holland areas where I started my career. So loop systems were much more prevalent in that area. And then I worked in Grand Rapids and then moved to Kalamazoo. So I have sort of moved with what I feel like is loops all the way down to Kalamazoo, where they're not as prevalent as they are in, say, Grand Rapids and Holland. But they're coming, and it is technology that a lot of people are using, or we'll find out later on that they do need. So it is a conversation with patients that even if we're not turning that on, because most of the time they have to access that manually, And we always are a little concerned that people are ending up in that program when they shouldn't be. But so it's getting that and then explaining to them where they would use it, what to look for, and then having that accessible if we do need to turn that on. So it is definitely something I look at doing.
But and certainly there is the case where people don't even know about telecoils. Do you talk about them at first when somebody's saying during your consultation? Will you mention a telecoil?
Yes, usually I do. So it's part of kind of fitting people into what it is that they need. So it's a conversation of where are you going? Are there commonly visited places that are also looped? Is your church looped? Are you going to the theaters in the area? So finding out what their immediate need is for a loop system or having telecoil access, and then maybe what they may want to do in the future. Some styles of hearing aids do not come with telecoil, so it is something where they are needing to, in some cases, look at what they're wanting, and then we help guide them into what is the best option for them, and can you get a telecoil, what is it going to look like, all of that.
Okay, could you also give a brief introduction also to Kim?
Sure. I'm an audiologist. I've been an audiologist going on 20 years, and I've been at Constance Brown Hearing Centers in Kalamazoo for about 16 years, and then I became their clinic director about 7 years ago. So I see patients half time and then supervise the audiology staff the other half. We have 2 locations. We are a nonprofit freestanding audiology clinic with 5 audiologists. We see both children and adults. We work with hearing aids. The things we don't do, we recommend cochlear implants, and we help our patients go there if they need it, but we are not working with cochlear implants at our center or not doing vestibular. Everything else we pretty much do. So.
Thank you. Michelle, can you comment on the telecoil question, since that's, I know you're clinical, and how you handle it at your office? And,
Sure.
and a brief introduction too afterwards.
Sure. So I have worked with loops quite a bit. I think they're very important. I think we underutilize loop systems. So I try to always order loops for, a telecoil for our patients. But I do find that patients get confused about manual access to it. I get a lot of feedback that depending on the phone they have at home, if they even have a landline anymore, that the telecoil doesn't work very well. It seems like the sound is far away. And some of that has to do with placement. So I spend a lot of time trying to educate patients on where to put the receiver for their phone up to their hearing aid. And then if it's a really in the canal hearing aid, it's hard to trigger that reed switch with the auto coils. So there's been just historically a lot of problems with the signal being not so stable, and primarily with phones. And now I'm like shocked at how many seniors have cell phones. A lot of them are getting rid of their landlines even, and they have Apple and Android phones, and they don't seem to work well at all with the telecoils. So I do try to encourage them to use the loop system when they're at church or when they go to public venues like Frederick-Meyer Garden and other places. But I primarily work with adults. I do have some college students that I work with, and I encourage them to use the loop when they're, in their university settings. But yeah, it's a hard question to answer. Loops are sometimes difficult to work with. It's just, it's an electromagnetic signal, so it's hard to control, and different phones are going to connect differently. They're hard to work with.
Okay, thanks. Could you also talk a little bit about your practice also? And I think you may have a couple locations, correct?
Thanks to COVID, no. But I'm Michelle Rankin, so I'm a doctor of audiology. I've been an audiologist for about 18 years. I spent 12 years working for an ear, nose, and throat group out of St. Joe in the Ann Arbor area. It was MOSA Audiology, or Michigan Otolaryngology. And then I opened about 6 years ago. I opened my own private practice. I work primarily with adults for hearing and oral rehabilitation. And I used to have 2 locations, one in Chelsea and one in Saline, but we had to close our Saline office. And so I just have the office in Chelsea. I have another audiologist that works for me part-time. So it's real small. We have 4 staff.
Okay, thank you very much. Karson, could you maybe comment on the telecoil? How do you handle those?
Yeah, it's typically a part of the conversation when we're talking about hearing aids because it can be a huge advantage, especially if people, if their church has a loop system, if they're going to theaters at all, anything like that. We talk about it, and it can just be a huge improvement for their enjoyment. So yeah, we talk about it typically with everybody who comes in for an eval. Yep.
Okay, all right. It's got to be pretty typical. I know HLAA is real big on loops, so they don't want to see them disappear.
Mm-hmm.
So, all right, I'll go on to the next question. This is relating to the telecoil program. Why is it not turned on when young children first get their hearing aids? It allows the school audiologist to try amplification systems that they have equipped at the school before allowing the local school to purchase the Roger pen or the Roger system, such as an equipment would be the MyLink universal receiver for young children to try before the actual Roger system. So I guess this is something that maybe the parents are expecting the telecoil to be on automatically when if that indeed is in there, but maybe it's more for parent advocacy. But any comments on that? Go ahead, Karson, you can start with that.
Well, it might be a breakdown in communication. Why it might not be turned on or activated. And that might be just it's really hard to say why it wouldn't be activated initially, but I think it might be just a breakdown in communication there.
Yeah.
Anybody else add to that?
Yeah, I think schools have a lot to work with FMs, and there's lots of different types of receivers that kids can use. So if a school is using the MyLink, then they definitely can have their T-coils activated, but it's just going to depend on the age of the child and how savvy they are at turning on and off that telecoil program. And so the schools sometimes don't use FMs on very young children unless the child is able to tell the teacher about the quality of the sound. So we really don't want to use technology with our little ones unless we're sure that we're providing them with a very clear, crisp signal, and they're not getting any kind of distortion or anything. So it just will depend a little bit on how able the child is able to let the teachers know about the sound quality. But yes, the MyLink is definitely one of the options to try. I would say probably the signal from the Roger devices, because they're very technologically advanced, is probably better, and the other panelists can chime in on that one. I think the signal quality is better for those devices than for using the T-coil, because they're not quite so positional dependent. And so that might be why schools are maybe getting away from using telecoil for FM, but I will say that one really good use of the MyLink is if they do have different technologies on each ear. So again, speaking from a cochlear implant standpoint, if they have a CI on one side and a hearing aid on the other side, and they have a telecoil in both, then they can wear a MyLink and actually get the sound to go to both ears. So that would be another good use for using the telecoil.
So the only time you would need that MyLink device would be if you're not using a Phonak product, correct?
You can use a MyLink with any hearing that has a telecoil.
So a telecoil is necessary for most children then in the school system. For that
Yeah.
reason, you need to be.
Yeah, if they're going to use the MyLink receiver, then their hearing aids would have to have a telecoil program in them.
Yeah, and MyLink isn't really the preferred typically for receivers for FM for kids because you have to activate the telecoil, and just like adults, we're worried that kids are going to spend their entire day, once that MyLink is gone, in the telecoil program, where they're going to be picking up electromagnetic interference, they're not going to be aided properly, so that you do have to have a savvy child. Plus the MyLink, they're wearing it around their neck and they're fiddling, and it is a little bit more challenging for teachers and for the students. So usually out of necessity, they'll go that route, but I think most of the schools prefer using ear level receivers, and then some of the newer products actually will ghost, so to speak, a receiver into the child's hearing aid, so they're not even having to have anything hanging off of it to use FM. So that's usually, the telecoil is a good option with MyLink, but it's usually they try to get away from doing that.
Okay, I'll move on to the next question. There are parents who are unfamiliar with telecoil, and as a teacher consultant, I often find myself explaining what they are and why we want them turned on. So more of a general comment, I think, but yeah, that's, anybody want to add anything to that?
And I think it would go back to, it depends on the child's needs, whether that would be turned on or not. If you are using it for FM, certainly that needs to be on, and everyone needs to be counseled as to how to get it into that program and used appropriately. If you have an older child who's using a loop system somewhere that they're going, certainly that needs to be turned on. But again, that's kind of case by case. So for all children, we don't just turn them on unless there's a need, because again, we're concerned about them getting into that program. And a lot of hearing aids will have auto telecoils for phone that don't require that button to be turned on. So they are two different things in most cases, to where you could still have something that's using a telecoil for a telephone, but it's not a separate program that's turned on for loop systems. Those can work automatically where the loop systems cannot activate automatic. So sometimes if you're using it for phone, it doesn't mean that it is completely off in the hearing aid. It's just there's not a separate program for it.
Okay.
And I would just add that for any teacher consultant, I think the question came from a teacher consultant, is that correct?
Yes.
Sounded like. Ask the parent if it's okay for that teacher consultant to be in communication with the audiologist, because we're not with the child at school, and so we don't know necessarily what the needs are there. So the more we can have that open line of communication between the audiologist and the school, then we can definitely work together to figure out what is in the best interest of that particular child.
Mm-hmm.
Thank you. Okay, let's move on to the next question. I wanted to extend the first question I asked about the someone coming in with a cochlear implant, and they want to know what can be done to improve the clarity of sound. Cochlear implants take a little bit of getting used to, but hearing aids, if I come in and I'm complaining, I'm going to probably complain that I'm not understanding speech. What can be done to the hearing aid? I mean, how much can you do to try to improve the quality of the signal?
I would like to address that if that's okay, Tony.
Yes.
Since that's kind of what I do all the time, every day. So my first question when patients ask that, well, the first thing we do when we evaluate a patient is to see how well they're going to do with hearing aids, how successful they're going to be based on their test results with regards to word discrimination, but we also do sentence and noise testing. And so we look at the type of hearing loss, the severity, whether it's conductive or sensory neural, and that goes into our choice of talking to the patient and counseling on what type of hearing aid to get. But it's so important to communicate to patients that hearing aids don't fix their hearing, especially if they have sensory neural hearing loss. And there's also other types of hearing loss called hidden hearing loss, that even if you have a mild or a moderate hearing loss, you might have very poor word recognition. And so we try to counsel the patient ahead of time for realistic expectations as to what a hearing aid is capable of doing. So it certainly can't fix their nerve damage. It's taking a microprocessor, a little computer, and manipulating sound and entering it into their auditory system. But if that auditory system is damaged and there's cochlear distortion, then the hearing aid is like a tool, right? It's a tool for communication, but the other communication repair strategies are so important when it comes to understanding how hearing aids are designed to work. You know, and that's so hard today where everybody's wearing a mask and you can't utilize speech cues and visual communication. So we're seeing just so many patients coming into the office who are frustrated with clarity because of masks. But even when you're not wearing a mask, you know, just ensuring that the hearing aid is programmed and that real ear measures are done to ensure that the patient's getting what they need in terms of, you know, their auditory perception. But, you know, sometimes that's very hard to achieve when there's other issues going on with the patient's hearing. And some people just can't hear in background noise, and it's really not necessarily the hearing aid, although there's some great hearing aids out there that have artificial intelligence that help control for that background noise so the person's brain doesn't have to work quite so hard to filter it themselves. It just depends on the hearing aid and on the patient. So it's so important to test aided and unaided sentence and noise and word discrimination, and try to wrap yourself around that patient and what their specific needs are, and how to counsel not just them, but their families on understanding hearing loss and how to communicate effectively together using communication repair strategies and appropriate communication. Don't talk to somebody from another room. That's not appropriate. It's not how humans are designed to talk to each other. It's, you know, face to face and speaking clearly and trying not to topic change and all those.
I have to imagine from an audiologist standpoint, not being able to hear what that person hears, probably a big challenge, probably the biggest challenge for you. You know, you have to base it on what they're telling you and what the manufacturers are suggesting for those types of complaints, I suppose.
Yeah, we try different algorithms when we have patients. So this is an interesting case. I had a patient in the other day. He had been in one manufacturer's hearing aids for many years, and then his insurance changed and he ended up in a different manufacturer's hearing aid, and he wasn't doing well. He was really struggling. We put him in the booth and did speech and noise testing in one algorithm, and he did terrible. And then we switched his algorithm and put him back in the booth and did speech and noise testing, and he knocked it out of the park. He did great. So it's fascinating to see that, because we just mimicked an algorithm that was closer to what his brain was used to hearing. So, and then he did absolutely fine. He was absolutely tickled pink, and we didn't change anything about, you know, his volume, because it's not about volume. Clarity is not about volume. Volume can actually cause more distortion. So yeah, we didn't change his volume. We just changed the mathematical algorithm in the computer chip in the hearing aid, and it made all the difference in the world. So it's just taking, it's important to take time with the patient to understand their needs and their past, you know, taking history about their medications that they're taking and their past experience and you know, their history with the hearing loss. Is it a noise-induced hearing loss, or is it an ototoxicity from a chemotherapy, or, you know, is it genetic? How long have they had the hearing loss? There's so many factors that go into making all of these decisions, and it's really about patient-centered care. You would need to know your patient and what their needs are if you're going to serve them appropriately with communication, because the hearing aid doesn't fix communication skills, it doesn't fix hearing. It's just part of the package, right? It's the tool that we use to try to improve somebody's quality of life through better hearing and better communication.
Yeah, that's interesting. So thank you. We'll go on to the next question. And it says, I have heard from families that their child thrived with the FM system at school, and they would like to have that option in their own home. Do you know of financial support options for families to get these systems at home? Can FM systems work as effectively in a home setting? Anybody want to?
Do you want to take that one?
Sure. if you're talking to me, if anybody else wants to jump in. So it can work in the home depending on what you're using it for. So definitely they're great in school because you have one speaker who everyone needs to pay attention to, and you're in a poor acoustical environment. Whereas at home, you need to be careful what you're using it for. They have really great purpose for the car, especially because, you know, if that it's such a good teaching moment for our kids. We know when we're traveling in the car, but for hearing impaired children in the back seats, they're not going to be able to pick that up another way. So FM is great for that, or when they need to focus in on just one person, it's great for that as well. So it's good for those certain situations where you really need to be focused in on one person that's talking at home. There, as far as cost-effective options too, a lot of the newer hearing aids can come with, so it doesn't necessarily work on FM, but you can get remote microphones for a lot of the newer devices that are actually very inexpensive, and some manufacturers even include them for children especially. So it is something to look at and talk with the audiologist about, because the way that works is a lot of times it's working on Bluetooth. It depends on what you have, but it's just a microphone that the parent will switch on, and it'll work a lot like FM. It just has a little bit less of a range sometimes, and maybe a little bit more interference, but really does serve its purpose for a majority of situations that child might be in. So that's definitely something else to look at.
I think you hit the nail on the head with the one, you know, you got one in a classroom, you got one teacher doing all the talking. So at home, you would probably need, I guess, could mom and dad have separate mini mics, remote mics, and then can two mics pair to the same hearing aid or implant? Is that an option?
Yeah, and there's always that. I think sometimes you can work with that and kind of get two transmitters for a microphone. But the other thing to be aware of, especially with children, is a majority of kids, especially with hearing aids, I can't speak as much to cochlear implants, but they are needing to learn to process sound in different environments. And so sometimes in a home environment, working on using strategies and having them listening in that environment and to the speaker without it transmitting directly to their hearing aid. So learning to process that sound the way it's coming through their hearing aid microphones rather than trying to transmit that all the time, because it's not a real world situation. And so you do have to be a little bit cautious that you're using that at times when it's appropriate, and then at other times the child is constantly learning, and those connections are being formed to process sound in various environments and to localize to sound and to take environmental cues and things that they might be missing if you get too focused on FM or speaking through a microphone.
Good point. Good point. We'll go on to the next question. In regards, excuse me, in regard to hearing aid checkup and reprogramming, what cadence is recommended for children versus adults? Anybody want to attempt that one?
Another big one. I think it goes back to formula fittings, and right, Kim? I mean, you want more input for children than you do with adults. Less filtering for kids, more filtering for adults.
Yeah.
I don't fit kids, so yeah, Kim, I was trying to.
Yes, no, of course. So yes, was the question that how you would set hearing aids?
Yeah,
So
apparently they're coming in. There's the programming differences between children and adult. I mean, so much depends on what the audiologist is getting, but I don't know if there's any difference between. I mean, if there are different procedures that you're going to do with a child as opposed to an adult.
Well,
so for those of us, yeah, for fitting hearing aids for children, so now they actually do make pediatric hearing aids. So most of us that are fitting children are working with pediatric hearing aids versus adult hearing aids. And how they do things differently for children is they do allow you, so when for younger children, they need very little processing. They need to learn to do that on their own and need to have their brains forming those connections so that that can happen. So they need less processing from the hearing aid, maybe greater amplification for certain sounds than some of our adults are willing to tolerate. So for children, it is all about audibility. We're just trying to get them as much of the speech range as we possibly can without the hearing aid interfering too much in what they may be able to learn to do naturally. Whereas our adults, they're coming with a little bit more baggage, and they've maybe lost their hearing gradually over time, but they had hearing to begin with. So they, in some cases, are losing their ability to process sound and background noise. They're not as well at processing a filtered signal, things like that. So they need a little bit more assistance from the hearing aid at that point for different environments. But then also, it's always sometimes difficult for adults to tolerate certain sounds. So that's where you get into where everyone hears a little bit differently. For a lot of our adults, if you get too much bass in, they're getting too much echo in their own voices. There's too much occlusion because they're just not used to that. Too much high pitch, and like Michelle was saying, sometimes that interferes then. It doesn't always, it can create distortion. So it's, with adults, they need a little bit different processing than our children do.
Karson, do you want to add to that then?
No, it's just, you know, it depends so much on the individual, right? It depends on the hearing loss, whether or not it fluctuates. You know, so there's no one answer. It has to be on a case-by-case basis, and yeah.
All right, we'll go to the next question. It says, one of my biggest challenges with hearing aids is talking on the telephone. I cannot read lips or see body language when talking on the phone. Amplification doesn't seem to improve the clarity. Are some phones better at amplifying than others?
So I'll jump in there to start this one. I think there are several options to improve speech understanding on the phone. One is now hearing aids can connect directly with your cell phone, and you can get that audio signal directly to both of your ears, and that can be a huge advantage for some people. And if they don't have set of hearing aids that does that, then that's one of the first things I would look into, especially if they're on the phone a lot. If this is somebody who is working and needs to take calls pretty frequently, and that's something that right now especially can be more frequent, then that might be something to look into. But there are also some phones like the, I don't know, is the Dex phone still an option for Phonak? Does that still exist?
I think it still is, but I don't know how much they use it anymore.
Yeah, okay. But options like that where you have a landline phone that will connect directly to hearing aids as well, or a T-coil too.
And I think, I know that Caption Call is one of the sponsors of this group, but I do recommend captioned phones to a lot of people. It surprises me that a lot of people still don't know about the availability of captioned phones. And that can make all the difference for somebody to help just give not only, you know, if they're not hearing well, but maybe they're hearing well, they're just not confident in what they're hearing. And so just by having that added benefit of being able to read what's coming, you know, what's coming through the phone just makes all the difference for them and helps them to be more independent. I think people don't like to have to rely on other people for their phone calls. They want to make independent phone calls. And so that's definitely one way that they can do that.
Good point. So yes, that's certainly a solution to help on the phone. And I know Bluetooth is probably the biggest thing for me. And as Karson mentioned, it comes into both ears. That's why many people put their phones on speakerphone, because we can hear better with both ears. So the next question is, I'm noticing that Karson is wearing a headset. Is it equipped with a mic? When he spoke, it did sound like he was clear and near to a microphone, whereas the other panelists appear to be using the computer mics.
Yes, I typically use this headset because it does have a microphone built in, and it just makes things a little bit easier with Zoom kind of setting.
So the microphone doesn't go in front of your mouth, and yet this is pretty clear. I'm actually impressed with that. So I may have to ask you later what that is. Maybe somebody will have an interest in that too. So sure. It is nice. We're always looking for wireless solutions. That doesn't have a cord behind your, okay, it's completely wireless. Great. Okay. Nice.
I hope everyone can hear us okay, even those of us old schoolies who are, you know, using our computer mics.
Yeah.
Okay. Just a note on the computer mics, the sound sounds further away and distorted. So,
I'm sitting as close to my mic as I can without you being able to see up my nose. So I hope it's coming through okay.
Okay, here's a bimodal question. What is the process to ensure hearing levels on both hearing aids and cochlear implants are providing a balanced and harmonious listening experience to the affected individual?
Well, if we know how to do that, then, you know, everybody would be all set for their hearing. One thing to keep in mind is that the way that the individual is hearing with their cochlear implant is completely different than the way that they're receiving sound from their hearing aid. I do ask my patients if they feel balanced when they're wearing a cochlear implant in their hearing aid, or if they feel that one is louder than the other. A lot of times, just because of the nature of the hearing loss, the cochlear implant can provide more high frequency sound and give them a little bit broader spectrum of sound to their implant ear. So that ear may always seem dominant over their hearing aid. On the other side of things, sometimes people have a hard time getting accustomed to the sound from the implant and will always want the hearing aid to be louder because that's kind of what they're used to. So we do try to verify, you know, just that each ear is getting the best fit that we can for both sides. But a lot of times because the sound is different, it's just, there's going to be differences there.
Okay, we'll go to the next question. Do you often have patients who would benefit from hearing aids but are reluctant to get them, whether it be denial or pride? How do you go about this?
All the time. Nobody wants a hearing aid, right? And it can be very difficult for somebody to come to the realization that they end up wanting a hearing aid. It might take several times, several discussions talking to somebody, or maybe a spouse talking, for them to come around and eventually purchase. But I think it takes just a frequency of conversation there.
Yeah.
Okay, I'll move on to the next question. Does the panel have an opinion about Westone and Microsonic ear mold services? The materials used are different.
Yeah, I know at our clinic we use both, and probably a balance of both. So I haven't noticed a big difference or a preference for one versus the other. So for ours, we kind of go with both. Some seem to be better for, maybe a little better for certain materials than others, or maybe certain colors. A lot of our kids are very specific about that. So I think Microsonic has a little bit more range, but otherwise we do probably a balance of both.
Is there like a hypoallergenic component in both of those? So if somebody's complaining, I mean, you probably have instances where maybe somebody says this is still too itchy all the time, so then you may have to go to a different manufacturer for whatever reason. So
Yeah, so there's things you can get with coating, and we can work with both of them. A lot of times just getting clear without any dyes in it is, and most of them will say that all of their materials are hypoallergenic, but there are some coatings and things that can get put on if you're very sensitive, or just get it free of any kind of dye, and that usually does help most people.
So that does kind of like open up another question about the hypoallergenic coating that they put on those. Is there things that you could do to damage that coating? Like if I wanted to clean it with alcohol, is that a bad thing?
Yeah, so alcohol is not recommended, especially for cleaning ear molds. It can make them more brittle. It probably could affect the coating. So you want to look for things like, I know there's audio wipes are safe to use on ear molds. They are rated to kill most bacteria too, including COVID. Now they're saying, so that is more effective way of sanitizing. Those are recommended more for any kind of earphones, your hearing aids, any ear molds. You want something that's actually designed for that versus alcohol that can discolor it as well.
Great, thank you. Let's see. I have heard conflicting direction in regard to the use of the drier box, meaning if I should leave the battery in the hearing aid when it's placed in the drier box, or is it recommended to not place the battery in the dryer?
I would not have the battery in the dryer.
I think I've read conflicting reports. I've heard some battery manufacturers say the battery, it doesn't matter if the batteries go in the dryer or not. I would just encourage people to do your own little experiment. Put your hearing aid in the dryer with the battery, and then try that for a few days, and then try putting your hearing aid in there without the batteries. And if you notice a significant difference one way or the other, just do whatever works for you.
Yeah, I usually tell people just keep them in there. They're more likely to use their dryers. I've noticed if they're not taking the batteries in and out, and it seems to have very minimal effect, but again, it may have some. So if you can do it, probably a good idea. But otherwise, it doesn't make
honestly,
too much difference.
And I've been telling my patients, so many of the new hearing aids are nano coated and they're pretty water resistant, that, you know, having a decusant puck or, you know, little silica packets in their regular case instead of using a dry aid kit. I mean, I guess it depends on what they're doing and how susceptible their hearing aid is to moisture, but trying to keep it simple. Like you said, people are more likely to take care of it if it's easy for them.
Yeah, and a lot of the rechargeables too now, because there is no battery door on a lot of them. They are telling people just to getting away from that a little bit because moisture is not as big of an issue.
That is interesting. Something I never thought about, as because I've always used the replaceable batteries. I haven't moved into the rechargeable yet, and so yeah, that's something that I haven't been exposed to. So that's an interesting point. So a note came in from Facebook saying that all doctors with telehealth should get the headphones Karson has. It's awesome. It's awesome.
I'm taking notes. Yeah.
Yeah, there you go, Karson. A side job for you.
Go.
All right. Face masks are audible communication barriers, and depending on the mask can result in significant decibel drop that can adversely impact speech understanding. Can you recommend micro mics that fit in a face mask and will transmit sound to a hearing aid or a CI? A mask is being developed in Japan that has a mic and ability to translate languages, and they provide a link to this particular product. So that is interesting. It's obviously an article that came from CNN. So can anybody, I suppose that's a great point. I'm glad that this person pointed this out. But can you talk about the loss in decibels of these face masks?
I think
I was just, oh, go ahead, Karson.
I think the loss in actual decibels or audibility is probably pretty minimal, actually. And I think it's a lot more about visual cues because you get so much information and you fill in the gaps with visual cues and being able to see what the face is doing. And when you lose that, even though it may seem like things are quieter, the biggest impact is the loss of visual cues and not necessarily audibility.
I 100% agree.
Darcy?
Yeah, I was just going to say, I looked at an article that Starkey, I think, had published just recently about, and they kind of tested audibility with people using all different mask configurations and things like that. And I mean, Carson's correct. The biggest issue with masking is that we are covering our mouths, and so we're taking away all those visual cues. But think about distance too. I mean, the farther away somebody gets and they're speaking through a mask, that's a barrier. And so you are going to lose a little bit of audibility. And especially because we're talking about social distancing, we're putting that sound source farther away from, the listener's ears. And so, yeah, I think there definitely is going to be a little bit of a loss of audibility there, in addition to the loss of visual cues. So, there's all kinds of technology out there, and I'm not surprised to hear about, people coming up with masks that have microphones in them. That's very interesting. One thing I would worry about would be the amplification or the over amplification of breath sounds with a microphone behind a mask, but they probably have some kind of algorithm for eliminating that a little bit as well. Also sounds like a little bit of an expensive endeavor, since if it's a reusable mask, you'd have to have a way to clean it without damaging the microphone. So, but yes, what I forget what that phrase is, where necessity breeds invention, because this is the world we live in now, and so we need to come up with creative solutions for these things.
Suppose if you had a remote mic, you could actually just clip it right on to the side.
You know, even though the mask may not pose a big power loss, for people with profound, serious, severe to profound loss, I need all those decibels I can get. So I'm sure a lot depends on the severity of the hearing loss. So next question is, what would you as an audiologist want from us hard of hearing to prepare prior to an appointment, as to make the appointment as beneficial as possible for both of us?
I think the biggest thing is come with questions. I love it when people come in with questions, because it directs the appointment. It allows you to educate and just make sure that they are well informed, so they are able to make a good decision.
Okay, I'll go to the next one then. I've had people tell me not to put my cochlear implant into my UV dryer. Something about the UV makes the plastic brittle. Others say that's not true. Does anybody know that answer?
Yeah, we used to, cochlear implant manufacturers, some of them used to include those electronic dryers into the cochlear implant kit when they would get it. And that kind of earlier generation of electronic dryer did include a UV light. The idea behind that was supposed to be some kind of antimicrobial light to kill germs and things like that. I do believe that they still have that model available, but the cochlear implant manufacturers did kind of see that it caused some discoloration and things like that into the plastic that is surrounding the processor. And so then they decided to go with a model that didn't have the UV light in it. So most of the dryers that we're using now do not have that UV light anymore.
Interesting. Okay, let's move on. Experiments indicate a potential 12 to 20 decibel drop. I'm assuming that was about with the mask. And I know I read an article that there was a decibel drop in those masks, maybe significant. 12 to 20 sounds a little extreme. I'm not sure if that's completely true, but that's what it was.
It might be for certain masks. I think it does depend on the mask and how the mask is worn. And I mean, there's, again, so many variables, even how the person's speaking, right? Like who's talking. So yeah, even without wearing masks, how somebody projects their voice varies from person to person. But,
Right.
I think it's a combination. No, that's okay. Go ahead, Karson.
No, and it might actually change the way the person is speaking.
Mm-hmm.
It might totally change. Yeah.
This person said a Roger pen could be helpful. So maybe put the Roger pen. That would be you're going to give somebody that you're speaking with the Roger pen, and that Roger pen is connected to your hearing aid. So yeah, that's another piece of hearing assisted technology that could possibly help.
Yeah, those remote mics in any form they're great. As long as sometimes people are shy about using them. Some of my patients, they feel funny asking somebody to hold the mic or clip the mic. Even in their own families, sometimes they get teased, and that goes back to education. People think hearing loss is funny, and it's not.
Yeah, it's sad. It is sad. That could be another whole conversation there, because when it's different. I was born with hearing loss, and people that have later onset, sort of different circumstances that control that. The next question is, I'm in the process of becoming a mondegreen beam and have moderately severe tinnitus. I am a little hesitant to get a hearing aid because the tinnitus is exacerbated when my ears are covered. Is there anything that can be done? I'm not sure if
Question. I don't think I understood the question.
Yeah, I'm a little confused. It says I'm in the process of becoming a mondegreen meme, M-E-M-E, is that meme? Mondegreen meme, and have moderate severe tinnitus. I'm a little hesitant to get a hearing aid because the tinnitus is exacerbated when my ears are covered. So there must be something that, some kind of a tinnitus treatment that when your ears are covered, I'm assuming. So let me ask the person that posed that question some clarification on that, because I'm not really quite sure.
I think somebody could probably talk to how covering your ears is going to be different than wearing a hearing aid. And so I defer to my colleagues about the hearing aid specifically with tinnitus, but a lot of times we do recommend that they try amplification because it can sometimes mask the tinnitus. So I'll defer to you guys.
So I wear hearing aids with the mild hearing loss, but I have pretty significant tinnitus. And so I use tinnitus masking in my hearing aids with amplification. So, and it's great. It doesn't, it doesn't exacerbate the tinnitus, it makes it better.
We're getting a lot of noise in the background. Is that, do we know where that's coming from?
It's not my house. I turned my clock off.
It might be me. I'll quiet it down.
Okay. Well,
Yeah,
I hope we've answered the question. Maybe not, then the person can chime in again. We still have about 14 minutes or so. So from Facebook, I wear bi-lateral BTW hearing aids. I'm assuming it's BTE hearing aids. Can you talk about stethoscope options? So I'm assuming behind the ear hearing aids, and they want to be able to use stethoscopes. So
That's a hard one. I've had some physicians that have come to me with that same issue. I think I had an anesthesiologist. We ended up getting CIC hearing aids, and then he got amplified supraoral. You can buy special stethoscopes. Are very expensive. They can be upwards of $1,000 for those amplified supraoral stethoscopes. And it's just hard because if you use an amplified stethoscope, you take your hearing aids off every time you use the stethoscope, and there aren't really any stethoscopes that I've seen, correct me, panelists, if I'm wrong, that have any kind of Bluetooth capability or can connect to BTE hearing aids. And I've had nurses too that I have fit with hearing aids who have had to buy special stethoscopes, but combining them, it's very difficult.
I think I think there are wireless options out there. The last time I had to research this for somebody, again, I usually have to research it for those with cochlear implants, but I would probably refer the person to like Hark Mercantile, so an organization that has a lot of assistive, listening devices. I know that they do have some models of stethoscopes available, and it might be kind of a trial and error type of thing to kind of figure out what works best. The sounds that they have to listen for also are sometimes quite very low frequency sounds. So there again, you might need to have a program in your hearing aid, which would be specific to stethoscope use for listening to some of those sounds that they need to listen to. But there definitely are some options out there, and see if you can check with, oh yeah, Jared just posted the website there. Definitely check some different ones out and see what works best.
Mm-hmm.
Yeah, good point. I didn't think about a special program that somebody may need for using a wireless stethoscope. Good point. And there was also a post, a question, basically just pointing to some sources on speech degradation with the mask. So there was a couple links on here. So I appreciate that input from that viewer. The next question regarding mics. A friend uses a remote mic with a long arm, example 24 inches, a long arm remote mic. I don't know what that means. What a long arm A remote mic for what application? 24
Maybe
inches.
for a
Yeah, I guess
computer.
that
Maybe
depends
for
on
a
the-
computer or something.
Yeah, yeah. Because I know the range on those microphones on mine, I got a remote mic and it's about 80 feet. So it's a very, very long distance. So, so yeah. All right, well, I'll move on to another question that Michelle mentioned earlier about real ear measurements. Are a lot of practices doing that yet? I know that it's kind of like one of those emerging things that may not be very popular because it is a little bit more time consuming to perform. So can somebody talk about the real ear measurements?
And we're doing them in our clinic. So, and I think it's a very important part of the process in getting them fit just right. I mean, there's only so much that can be done to get them set right. So we're using the manufacturer's prescriptions, but that's not taking into account how that instrument is functioning in their ears. So typically what we'll do at our centers is kind of start by broadly getting them set, run some of the features in the hearing aids, and then always back it up with real ear measures and then kind of tweak it from there. Some people I know, for us, we're not always focused on that at the fitting per se. It depends on someone's experience level. If they're just starting out and can barely tolerate amplification, we'll work them through some of the adaptation and then eventually work our way into getting them exactly at the target that they need to be at. But that is the goal, is to get it to a real ear target so that you know exactly what it's doing in their ears. And for children, we rely on it. So that is the only way to fit pediatric hearing aids, is really to find out what it is doing and do those measures. Otherwise, you really run the risk of over amplifying.
Okay, we're getting, go ahead, Karson.
No, I think it can be an important troubleshooting step too. If something's not working right, you can really figure out exactly what's going on and make fixes based on that.
Well, thank you. We have one last question before Jared wants to terminate. We're getting near the end. So what is done with no longer used hearing aids? Are they recycled, discarded, or can they be reused for financially less fortunate individuals? So I guess this means, do you take those, can you take a used hearing aid in your office and repurpose it?
Yes.
Usually when I take in used hearing aids, I give them we usually donate them to the Starkey Hearing Foundation.
I know the Lions Foundation also will do some refurbishing, and we'll take advantage of that.
Yeah, we send to the Chicago Hearing Society. They'll take everything, including custom. So we work with them. And I know at our center, we take them. We're nonprofit. So some people do use them for a deduction. And then we use as much as we can of them to help in any way that we can with the products, and then donate the rest.
One of the things I'll add to that is if somebody doesn't have a backup pair, keep it as a backup first.
Yeah.
Oh, yeah.
Definitely.
Okay, I'm going to turn this back over to Jared for the closing. I think we got all the questions. So there's some information in the chat that people may want to be looking at. And you can save the contents of that chat box by clicking those three little dots in the chat, and it'll bring up a little dialogue that says save chat. So you can save the contents of that rather than writing it all down. So Jared, can you take it from here, please? Thank you, panelist and captionist, Denise, everybody working in the background.
Great questions from everybody too, so.
Karson, thank you for your service. My son's in the Army. Appreciate it.
Okay, so, whoops. We see the PowerPoint, Jared.
I'll take it over. He can't speak.
Okay, okay.
Yes, thank you very much for joining us today. Those were great questions and great answers, so thank you. We wanted to thank everyone for attending and let everybody know about our Facebook page and also our website page. And just a reminder that the next Ask the Audiologist panel will be March 17th, 2021. Again, that will be virtual. And then the Walk for Hearing will be May 22nd, 2021. Keep an eye out for more information coming soon on that event. And then the Michigan State is for HLAA is also looking to fill one spot for the Board of Trustees. So if anybody is interested, please feel free to reach out to us. And have a wonderful evening. Thank you everyone for coming.
Thank you.
Thank you.
Thank you.